In this particular presentation, we will go back a little bit to curriculum development and instructional development or instructional design because some of your classmates have not taken HP 221 or 211. Okay, let us now proceed. So when you talk about training or designing any training for that matter, you should remember at least two major concepts: the concept of process and the concept of product. So when you talk about process, you should think of the instruction. And when you talk about product, you will think of the curriculum. And therefore, process is about how it is to be learned, while curriculum talks about what is to be learned. You probably would wonder what will be the first. What will I do first? Will I start with um, deciding on the instructional event, or will I start with defining what is to be learned? Of course, theoretically or strictly, it will have to be always start with what your student will become. But we are put in a situation where sometimes what we have is, or we have been told to do something, and then after knowing what we're supposed to do, then we decide what we should teach in that particular context. Let's say in this particular course, we know that the context or the instructional event process will have to be community-based. If ever we are to decide what will be taught, it will have to be decided in the context of where it will be taught. But there are occasions when we know more where we want to do things, or we know more about the instructional event more than what we should teach. Let's say, for example, in this particular course, we know that we should be doing it in a community setting. And if we are to go back to what we should teach in the community setting, we will realize that there are competencies that may not be appropriate or may not be learned well in a community setting. Let's say, for example, you want high-tech competencies, then that high-tech competencies will require rotation in a hospital setting. But let's say you want to develop some competencies related to dealing with people in the community, then that will be that will be the best. So let's go back again to the two concepts. We'll talk about curriculum and instruction. And again, curriculum is about what to teach, and it would involve curriculum development, while instruction talks about instructional planning, and this will involve identifying how to teach. And to further illustrate this, let's talk about the curriculum instruction development model. For those who have taken CDID, this may be familiar to you, but for those who are taking CDID together with this particular course, then it might be useful for you to an advanced learning of all the competencies. So here we divided the presentation or the page into two groups: the output and the process, just like what we showed or I showed you in the previous slide. So when we talk about output, what will be the product of your process? That will be curriculum development and instructional development. Should be able to produce for you the values, the educational goals, curriculum, instructional plan, actual learning outcomes, and educational results. And when you talk about goal setting within that particular context, you actually will just need to answer one central question: why are you offering this program or course? So for your project, why are you proposing a particular course at a community setting? And to be able to define it well, you need to have a good conception of your learner, the society or the community where you are or where the students will be deployed. And of course, it will also give you a good sense of what the educational goal should be. Educational goal is different from intended learning outcomes. Goals are basically higher or more of attributes than specific competencies. Let's say be able to perform a clinical procedure is a very specific intended learning outcome. And when we talk about being a humane clinician, then that's an attribute. And that's the goal that we want. It's bigger than the specific competencies. And for curriculum development, meaning after we have developed the goals and we have identified the learners, then our next central question will be, what will I teach? And that could be in the form of your intended learning outcomes. And for PBL people, for example, we talk about conceptual maps of flowchart. If you'll be teaching, for example, algorithms, then you will teach algorithm. And you can just basically say at the end of the course, your student will be able to perform or follow this algorithm in making decisions. Of course, after you have identified your intended learning outcomes, you have developed your conceptual maps or flowcharts, the next thing to do is to decide how you will teach, and that will be instructional design planning. And your central questions will be not only related to identifying the general teaching strategies, but it's also important for you to consider the sequencing. A lot of instructional designers or teachers don't bother to even really think or process very well the grouping or the sequencing of event. More often, they just follow the book's sequencing, and this may not be useful. Actually, what you will learn in curriculum design is that never use textbook chapters as sequencing guide for your courses, okay? And that will be important here in the community setting. Maybe the traditional sequencing may not be appropriate when you're doing a community-based education program. Um, we will not cover the other questions or the other process. We'll do that later in the course. But now let's go back to the central question that I was talking about. Why are you offering the course? It's important because community-based education is uh, supposed to be guided by really important context or rationale. And rationale will have to be based on certain literature. And for us in the curriculum development group, for example, our teachers in health professional education, we do require several materials to help us identify the rationale for our course. So for the course that you will design in this particular, or you will propose for this training as your final, for your final paper, then you need to develop your rationale based on, for example, the basic papers. Basic papers would include your institutional vision, mission, goals, or basic papers about professions. It's also important to talk about health indicators. Why are we teaching, for example, certain things? Because we know that it is related or it has relevance in what's going on in the community. That's why the most common complaint about health professions program is that we are focused too much on some diseases that does not even exist or don't exist in the Philippines. But we also need to project what is the future in health. Is the future in health on CVDs? Are we moving from infectious diseases to cardiovascular diseases or lifestyle diseases? Are we moving from this kind of diagnostic tools to the more digital diagnostic tools? So will we still teach our students this protocol when in fact maybe when they graduate there will be new protocol or new protocols for diagnosis? And of course we need to also talk about best practices. Even at the community setting there are best practices. Um, you cannot just transfer or transplant a method, a teaching method, to community setting because it may not work. And in the context, in our own context, looking at all of this, we also need to go to one of the very basic, which is universal health care. in the next few years, if law will not be changed, that is our law. And anything, even healthcare financing plans are based on the universal healthcare principle. So all of this together should be able to give you an idea of what your training program should value and what educational goals it should target. So these values and all this information that we get from UHC health systems and all the other information about epidemiology or health statistics, health indicators, health futures, best practices, and as I said, the basic paper about our institution, basic paper from WHO, DOH, your specialty societies, PRC, CHED, they all would contribute to our own process of identifying the values and educational goals for the training program. And these values we know would help us define who or what a healthcare professional should be. And after we've done that, of course, we go to identifying the more specific internal learning outcomes. If going back here, from, as I said, from the systems, from all the information on the right side, you go to the values and goals, and then you go to the healthcare professional. And all of the information that you gathered should help you identify the roles and the responsibilities of your health professionals. Are all these roles to be played at the healthcare facility setting, or some of these roles are best performed at the community setting? Or are these roles present or should be performed in any setting? That be you be in a community or you're being in a community does not exempt you from doing or from being good healthcare provider. And at the same token, being in a hospital does not make you does not make being educator less important. And you know that from the roles, then you will be able to break it down further to responsibilities, and from responsibilities to specific knowledge, skills, and attitude. And we call that particular process the task analysis process. We'll go through that as we move forward. So, to go back again to identifying values and educational goals, we need to go back to some very basic materials that should help guide us in doing so. One would be, for example, materials on integrating patient-centered care in community-based education. I think that's very important. So when you talk about integrating patient care, we also need to look at the context why it was actually advocated by WHO. If we go back to former director of WHO, Director General Dr. Margaret Chan, she said this: "In matters of health, I believe our world is out of balance. We never before in history, we have never such a sophisticated arsenal of technologies for treating diseases and prolonging life, yet the gaps in health outcomes keep getting wider." Meaning, while more technologies are developed, it did not result to better outcomes, especially of people in the peripheral or in the periphery. Yes, you may have technology, but we don't have access. So let's contextualize this using these three women with breast cancer. So reflect. So it's a few minutes here. I'll share with you the case and then try to reflect. This will be a case of three women with breast cancer. And let's see what happened to them Are there differences in their experience? Were there differences in terms of outcomes? What factors may have influenced the outcome? So let's listen to the story.
Maria from a remote village in Samar was attending a health education class on self-breast examination. During the session, she felt a lump the size of a marble in her left breast. The village has no health center and the nearest was an hour away. By the time she found the time, 6 weeks had passed. Staff at the nearest hospital did a biopsy, but she was advised to return after 2 weeks. When she came back, it was more than 2 months later. The doctor gave her the bad news: you have cancer and needed surgery, which is not available. By the time she had the chance to go to the regional center where surgery can be performed, tests revealed that her cancer had spread to her lymph nodes and liver.
So that's Maria. Let's look at the second woman.
Lorna, a married school teacher in Batangas, was scared. It was time for her yearly mammogram, and this year the results showed a new mass in her breast. After the biopsy, her primary care doctor called her in. The visit lasted a long time. Lorna had many questions, and she and her doctor talked about all of her options. "Doctor, I'm scared. Will I die?" she asked. He looked at her directly and replied, "I don't have the answer to that question, and it's normal to be scared. But I can tell you this: today, we have effective treatments for breast cancer. There's a good chance to cure. You must believe this, Lorna. You must do all you can to aim for a cure. I'll help you." And help her he did. The doctor arranged for Lorna to see a cancer specialist and join a support group for women with breast cancer. It was a difficult period. Often, Lorna was too weak to do anything but lie down. But the worst part was when all her hair fell out. To cheer her up, Lorna's husband and son shaved off their hair. It worked. After 6 months of treatment, with her family and her primary care doctor to support her, Lorna's cancer was declared to be in remission. Cautious, but optimistic, Lorna returned to work and eventually became a volunteer at her local cancer society, reaching out to other women with breast cancer.
And let's look at the third scenario.
Our third case is Sandra. Sandra had recently moved to Metro Manila from Mindoro. Through her company's health insurance coverage, she had access to one of the largest hospitals in Metro Manila. When she was diagnosed with breast cancer, she comforted herself with the thought that she would be treated by some of the best medical experts in one of the most modern facilities in the country. It was true that she received state-of-the-art care, but the experience was not what she expected. First, she was away from her friends and family, and no one was with her throughout the treatment period. Next, navigating the health insurance maze proved to be almost as formidable as going through chemotherapy. Understanding and obtaining insurance pre-authorization for treatment proved overwhelming. Finally, the hospital environment, while efficient and clinical, was also cold and harsh, especially for someone fighting cancer alone in the metro. By the time Sandra was declared cancer-free, she was also experiencing full-blown depression. Unable to keep up with her job, she eventually lost it, returning to her province healed in body, but broken in spirit.
So you have three cases here, three different cases, but three different outcomes. Why is it important? Because this would help us more or less identify the context that would be the basis for the rationale for our courses. So this may be useful for a clinical setting cases with breast cancer and how to prepare your doctors to deal with patients with breast cancer. But you also see a community respond or response to the patient, to the teacher, for example, with healthcare problem. So we realized that while the three women we just met shared the same disease and fought using one standard set of clinical guidelines, they experienced completely different outcomes. The differences were due in no small measure to the varying landscapes of healthcare they encountered. By the way, this is from a WHO case study or reading material on dealing with breast cancers. So that would mean that going back, for example, to Dr. Margaret Chan, the question would be, is development equals improvement in healthcare? And she said, a world that can put a man on the moon should be able to put children under bed nets. Today we have sent several men to the moon, but almost 30 years after the historic declaration of Alma-Ata that called for health for all, we are failing to meet the goal. Of course, the anniversary of the declaration of Alma-Ata she was saying here was several years back, but nevertheless, that's the reality. Now we know that scientific approaches and solutions that address the physical components of illness are necessary but insufficient to effect a total cure. Disease is not an objective state, but rather the product of our personal experiences. Understanding illness in this way, accepting that illness is intimately related to the patient's personality and experience, and understanding the doctor's role as helping patients to come to terms with or like to find personal meaning in their illness has a profound impact in the way we organize and deliver healthcare. So illness is a whole person, not a problem of one part. So therefore, when you talk about bringing training programs for health professionals to the community, that would also mean bringing the whole illness issue to the community. It is not just a person issue, it becomes an issue to the family and to the community. Another major thing that we need to realize was the years have focused our training too much on the hospital care setting because the healthcare system has been diverted from its core PHC values. In this figure from the WHO shows that supposed to be healthcare system is straightforward. Health system resulting to health equity, universal access, healthy communities. Unfortunately, that's not the case. Now health system is diverted downwards to add another layer before even going to people. That will be health system, then the current trend of hospital centrism, commercialization and fragmentation. This all influence the way healthcare is delivered and the way health services is managed. So since these are the trends, even our training programs move towards more hospital-based. Our training program basically influence commercialism. Sometimes graduate of medicine would choose a certain residency because of its commercial value. People are just going to doctors of the barrio because of the salary grade. But that's very temporary, so after they probably have rested from their medical school and earned a little bit, they go back to their dream of hospital-based training. And of course, it also resulted to fragmentation. People would always tell me in the community that before, or even in my own experience, before when we have some health problems, we go to one doctor in my town, and that doctor will also be the one treating my mother, my father, my cousins, and all of the people. Now, if you have a cough, you go to pulmonologist. If your knee is hurting, you go to your rheumatologist. See? And suddenly we lose the importance of primary care and general practice. So what we're trying to advocate is that we bring this back to this original idea. which is health systems, straight to health equity, universal access, and healthy communities. No additional version, straight. And that would mean embracing social values that drive primary health care. And that would mean working for reforms, and that reform would include health equity, solidarity, universal coverage reforms. That's why we have the field health and universal health care, people-centered care. There will be service delivery reforms. Of course, we have leadership reforms. Unfortunately, that is being now with what's going on with COVID response. Suddenly, the OIC leadership is put in the limelight. And of course, reforms to make communities more advocates of health promotion and health protection. And that would also include policy or public policy reforms. So that when we do that, that would, or if we embrace the universal health care reform agenda, then we will have this new facility type that could be the health station, the comprehensive primary care facility, services that may be contracted, all the other types. And of course, if you know the types, you know what your students' future role will be. And you should be able to now readjust your courses so that they will be ready for this new or the revised structure of healthcare delivery. So you have the level 1, the level 2, and the level 3. But we should have more of the level 1. Unfortunately, we have less and less doctors going to level 1 because they all want to go level 2 and level 3. But we know that prevention, health promotion is still one of the most important tools for us to address diseases and to improve outcomes. So the key really is balance, and in an increasingly globalized world where people likely results from the or is compounded by the stresses of urbanization, environmental change, technological development, and demographic change, the biomedical mindset is no longer appropriate or effective. We have to start thinking of the new alternative to the purely biomedical model. And if we say we really would like to bring people to the community, this is one major reason why. Because the hospital is the, what do you call it, the one that propagates the biomedical perspective and removing or reducing the psychosocial components of health and illness. So to develop a competent and responsive practitioner, we need to consider all those that we have presented or I have presented. Because at the end of the day, we have to realize that we cannot fix people in healthcare because there are some mindset that are already there. You can fix things, you can help a person to be all they're capable of, but our goal is not to fix people, it is to help people become all they're capable of. We're talking about transformative learning. So bringing our students to the community is supposed to be in the context of not arrogating themselves or arrogating to themselves the health care, or that they are the only people who can produce the best outcome for health. We have to start thinking that we are in a community to help people become what they're capable of and become the agent of the change that they need or they want in their own community. We should not take away from the community that responsibility. What we should, instead of taking away, what we will give is capability so that they will be able to fix together with all the other stakeholders in the community the health problems that they are experiencing. So again, our response is the development of competent and responsive health practitioners, and that would mean treating and caring for a sick person is not just a matter of curing his disease. Patient has other needs as well. Being unwell can be disorienting experience. We've seen that in the three cases, for example. Living with fear or anxiety is not easy. For some, just being in hospital is stressful, particularly if it means separation from loved ones. And now we are seeing a lot of this in the context of COVID pandemic. According to the WHO, former WHO director for the region, in the past, doctors have failed to address these problems because they have been preoccupied with disease alone. Therefore, we will be aiming for a holistic approach to healthcare where the whole person is treated rather than just the clinical condition. This means dealing with people in the context of human dignity, their rights, their families, their culture, and the society. So that is Dr. Shiguro Omi, a regional director of WIPRO, or Western Pacific, where we belong. So with that, it resulted to what is known as the WHO policy paper on primary health care, or the strategic response to primary care, and that would be increasing capacity for holistic compassionate care. And here is where we come in: identification of core competencies of people-centered health practitioners. People-centered, what exactly are the core competencies for this needed to provide holistic compassionate care? We need to do promotion and integration of core competencies in all education and training programs for health practitioners. Promotion and integration of core competencies. Remember what I was mentioning about fragmentation? So the WHO strategic response is go back to integration. Probably teach subject in a more integrated way and even in the collaborative way. That's what we're doing in UP, for example, in our communities: integration, integrative practice, collaborative learning, and the development of comprehensive harmonized medical nursing and allied health curriculum and community-based training. See, WHO and the global community for involved in primary healthcare are actually pushing that we develop a comprehensive training that would involve exposure or bring our health professional or future health professionals to the community. These are strong in our rationale. And when we talk about that compassionate care or that holistic care, we talk about the ability of the doctor or the health professional to organize health care around the patient-centered approach. And who is around the patient? The family, the community. It would also involve communicating effectively to facilitate partnership with patients, other providers, and communities to improve health outcomes. The skills to ensure continuous improvement in the quality and safety of healthcare. So after a patient has been referred to a tertiary hospital, went back to the community, what happened next? What will now be the role of the initial physician? Or what will be the role of the initial nurse who processed or took care of the patient? So sometimes in other countries, for example, when you refer your patient to a specialist, that specialist will bring or will return that patient back to the original general practitioner so that the continuity of care can happen in the community setting. Um, the new skills to monitor patients across time using and sharing information technology through e-health, for example, we're pushing in e-health, telemedicine, and everything related to healthcare informatics. It's a major policy component of universal healthcare. and the ability to consider patient care and the provider's role in the broadest perspective, taking into account the multiple levels of healthcare system and the care continuum to include population-based care. See, it will have its curricular implication. I'm just showing you a picture of years ago when I visited one of the part of a group that visited a, a school for barefoot doctors in China in Nanjing province, and it was really fun because they are producing doctors who are supposed to be based in communities, the barefoot doctors, and they have a totally different curriculum. They have totally different training programs, and they do have a lot of herbal medicine subjects, and of course the traditional Chinese medicine. So when you address the issue of change, when we address the issue of creating more compassionate and more patient-centered health professionals, it will have curricular implications. And as I said earlier, it talks about paradigm shift from biomedical to holistic. So meaning we should not just look at the biomedical component of the disease, but also the psychological intervention for illness. We all know now that we have a lot of patients, especially with the COVID-19 pandemic, who don't have COVID, but they do have problems because they are stressed out. They may be even more sick than people with COVID. Of course, it's important to integrate from subject to system, from specialties to holistic perspective. Probably it would mean we will discuss this in the near future, in the next few weeks. But the thing is, like in sequencing or the organizing courses, you may have to start removing courses like anatomy, physiology, and integrate them instead in one course. It could be systems based, it could be cardiovascular system, where you integrate anatomy, physiology, pathology, and at the end, diagnostics and treatment. And of course, expand health experience from hospital beds to patient's family and to patient's community. These exactly are the things we're talking about on why we should start really thinking of developing training programs that could be or that would be community based. Integration at all levels, both vertical and horizontal, and of course, the community oriented components of every subject in the program. We always talk about individual care, but like pandemic now, the most important response to pandemic is community. If you start just looking at individuals, then you will have a problem. Even in our response now to COVID, we forgot the reality that people know people in the community. They can probably do better contact tracing than the rest of you or the rest of the policemen. Probably they know exactly the corners, the streets, the source of water, uh, and all the other exit points that may be important in doing a what do you call it, a comprehensive community preventive program for COVID, but we have not maximized that. So that's maybe a long introduction to the first part of your course that will be, or the first part of your paper that will be defining the rationale and the educational goal, and of course the competencies, the roles, the responsibilities, and the knowledge, skills, attitude that will be needed by your or that will should be included as part of your training program. So if you have selected a topic, if you have selected a program for your project, then you need to prepare a rationale for that. You need to prepare a task analysis for that. You need to justify, and you need actually we don't even need to justify. We just need to provide all the literature requirement to strengthen the need for this particular course that you're offering, or for the particular course that you want to offer in a community-based setting.